Welcome, and thank you for joining us. My name is Audrey Hassan, Patient Liaison for the MDS Foundation, and I'll be moderating the presentation today. Thank you to Bristol Myers Squibb, Jazz, Novartis, and Taiho for supporting this webinar program. Please note that this is a pre-recorded presentation, so the presenter will not be taking any questions. The live questions with answers opportunities for all participants are included at the end of this presentation. Today's presenter is Dr. Lindsay Wilde, an assistant professor of medical oncology in the Division of Hematologic Malignancies at the Sidney Kimmel Cancer Center at Thomas Jefferson University Hospital in Philadelphia, Pennsylvania. Dr. Wilde's clinical practice focuses on the treatment of myelodysplastic syndromes, acute myeloid leukemia, myeloproliferative neoplasms, and acute lymphoblastic leukemia. Her research interests center on the development and implementation of clinical trials using novel therapeutics to treat leukemia and myelodysplastic syndromes. Her work involves collaboration with basic and translational researchers to help advance the understanding of the biology of these diseases. In addition, Dr. Wilde also serves as the member of the MDS Foundation Development Board. With that said, it is my pleasure to introduce Dr. Wilde.
So thank you so much to everyone for joining today, and thank you to the MDS Foundation for inviting me to give a talk on this important topic of optimizing transfusion support in the care of patients with MDS. I have no disclosures. And the goal of our talk today is really threefold. So first, we're going to talk about understanding how MDS changes blood cell production. After that, we'll learn a little bit about how transfusions are optimally used in the treatment of MDS. And then finally, we'll discuss some alternatives to transfusions that are available and think about some new treatments that are on the horizon. So before we jump into the transfusion topic, I think it's important that we're all speaking the same language about MDS. And if you're not a blood cancer doctor like me, you may not think about your bone marrow or how the bone marrow works very often or at all ever before. So let's talk about what MDS is. In the simplest form, MDS is a group of blood cancers that are characterized by low blood counts. And in MDS, the bone marrow, which is the body's factory for blood cells, fails to make normal, healthy blood cells. MDS is really a spectrum of diseases. So on one side of the spectrum, MDS may present with very mildly low blood counts and require no treatment at all for some period of time or ever. And on the other end of the spectrum, some patients with MDS are very close to having another kind of blood cancer called acute myeloid leukemia, or AML. Wherever one falls on that spectrum is very important because that helps to determine how we can support and treat the disease. It's important to remember that about 35 to 40% of patients with MDS will ultimately progress to having AML. And so we have both supportive treatments that help deal with symptoms of MDS, but also disease-modifying treatments, meaning treatments that we use to try to stop the MDS progression to AML. So now let's talk a little bit about the bone marrow itself. What is the bone marrow? I'm a simple person. I like to think in simple everyday terms. And so when I think about the bone marrow, I think about it as the factory that makes our blood cells. This is a picture of a factory that makes jelly beans. I love candy, so I like thinking about a jelly bean factory. And like a jelly bean factory, a normal, healthy bone marrow makes lots of colorful, different kinds of blood cells. So this is a more technical diagram of our factory, the bone marrow, but it's really saying the same thing, that the healthy bone marrow makes three major types of blood cells. It makes red blood cells, which carry oxygen, white blood cells, which help us to prevent or fight infection, and platelets, which help our blood to clot and prevent us from bleeding. So a normal, healthy bone marrow should make all of these different kinds of blood cells as needed. But in MDS, that's not what's happening. So these are some abnormal jelly beans. They're not smooth. They look kind of funny. And this is what happens in MDS. In MDS, the bone marrow makes funny looking blood cells. So the factory is really broken. And these funny looking cells build up inside of the bone marrow and get stuck there. So even though there's blood cells being made inside of the bone marrow, when we check the blood through a regular blood test, we actually see low blood counts because those funny looking cells get stuck inside the marrow. And again, this is just another technical picture looking at the exact same idea, which is that this broken factory makes abnormal blood cells and they get stuck and crowded inside of the bone marrow, making ultimately the blood counts low. So low blood counts are really a hallmark of having MDS. So how do we diagnose MDS? Many of you probably know that we suspect MDS most often based on a regular blood test called a complete blood count or a CBC. And this is often a test that primary care doctors or someone might check if someone's not feeling well. And when we do that test, we see that the blood counts are low. And it can be any of the blood counts, white blood cells, red blood cells, or platelets, or any combination therein. But the blood count alone isn't enough to tell us that MDS is there. So MDS really needs to be diagnosed with what we call a bone marrow aspirate and biopsy. And this is a small procedure where we use a needle to go into the bone, most often in the back of the hip, and take out some of the bone marrow itself and look at it under the microscope. So we see with our own eyes how the factory is making blood cells and if those blood cells look normal or not. And this is really how we make the diagnosis of MDS. And then we use other tests like genetic testing to help us better understand where on the spectrum of disease that MDS falls. So does MDS always cause low blood counts? Yes, it does. As I said, low blood counts are a hallmark of MDS. So this is a study that is an indication of how we classify MDS on that spectrum of disease. And this is not really important or meant for you to understand necessarily all of this terminology, but this box in red where it says cytopenias, cytopenias is just another word for low blood cells. And you can see here that every single subtype of MDS has at least one blood cell that's low. So really low blood counts are the one thing that every person with MDS has in common. So why do we care? What happens when the blood counts are low? Well, a lot can happen. So we'll start with the red blood cells because I think this is the one that most people are most familiar with. Many people have heard of anemia, and anemia or low hemoglobin can happen for all sorts of different reasons. Hemoglobin is the test that we use as a measure of the red blood cells. And when patients become anemic, they develop symptoms of fatigue, maybe shortness of breath with activity, pale eyes or skin, and when severe, can even develop things like an abnormal heartbeat. So anemia is often a presenting symptom of MDS. White blood cells, when they're low, it's called leukopenia. And neutropenia is a word for low white blood cells that are of a specific type called neutrophils. And neutrophils are a very important infection-fighting cell. So when the white blood cells are low, you can imagine that infection is a big risk. So patients may present with fevers or other kinds of recurrent infections like sore throat that won't go away or sinus infections that keep coming back. And this is often a sign of low white blood cells. And then finally, platelets, as I mentioned, are those tiny blood cells that are the first responders when we get a cut. So when you get a cut on your skin, the platelets come and they make a little plug and they plug up that hole. So when the platelets are low, we see complications associated with bleeding. So that can be minor bleeding, like bleeding of the gums or bleeding of the nose when you blow your nose, or it can be more serious bleeding, like bleeding from the GI tract or blood in your stool or urine, or even more serious kinds of bleeding, like bleeding in the brain. The risk of bleeding is very much associated with how low the platelet count is. So how this presents is also on a spectrum. Patients with low platelets can also present with a specific type of rash called Petechiae. And this is just a little red pinpoint rash that's caused by bleeding in the skin that happens when the platelet count is low. So you can see that there's a wide range of things that can happen when the blood counts are low, and how low those counts are really matters at how much one is at risk for these complications. So what do we do about these low blood counts? That also falls on a spectrum. So if the blood counts are mildly low and someone is not having any of those signs or symptoms, then we may just recommend observing the blood work with periodic blood tests that you get at the lab. And if we see changes over time, then we may decide that we need to do some sort of treatment. The next option is what we call supportive care, and this is where we're going to focus most of our time today. Supportive care is what we do to help support those low blood counts and try to correct the problems that come when someone's blood counts are low. Supportive care doesn't fix the MDS itself. It just temporarily fixes the blood counts. And then finally, on the other end of the spectrum, we have what we call disease-modifying treatment. And disease-modifying treatment is usually given with a kind of medication, sometimes like chemotherapy or a cancer-treating medicine. Not everyone needs disease-modifying treatment when they're diagnosed with MDS, or ever necessarily. So which one of these treatments we choose depends a lot on what we see inside the bone marrow and what we see in terms of blood counts. But today, we'll really be focusing on the supportive care aspect because this is where transfusions really lie. So supportive MDS care comes in a bunch of different forms. As I just said, transfusions are the backbone of supportive care. And we're going to talk a lot about what transfusions are and how we can best use them. And then toward the end of the talk, we'll spend some time discussing what we call growth factors and red blood cell maturation agents, which are other treatments that we can use to support the blood counts in MDS and hopefully minimize the need for transfusions. So focusing in on transfusions now. There are multiple different kinds of transfusions that we can give. All of these transfusions come from blood products that are donated by another person. So this is when you go to the Red Cross and you give a blood donation, this is what happens to the blood. The blood is broken down into its various parts. It can be red blood cells, platelets, or what we call plasma, which is the non-red blood cell kind of liquid part of the blood. We aren't going to talk a lot about plasma today, but I put it here just because it's something that exists. The two most important kinds of transfusions for people with MDS are red blood cell transfusions and platelet transfusions. Many patients often ask me about whether or not we can transfuse white blood cells. It's a great question. In theory, yes, white blood cells can be collected and transfused. However, white blood cell transfusions come with a lot of associated risk and generally are not given in the treatment of MDS, except for under very rare circumstances. Personally, I have never seen nor given them in my career, but in theory, white blood cell transfusions are possible. But when we're talking about transfusion for the rest of our time, we're going to be talking about red blood cells and platelets. So when do we decide to give transfusions? There are a couple of what I consider guidelines or thresholds that we follow. First and foremost, what's always most important is the person in front of me. So if a patient is having serious symptoms related to low blood counts, that's a reason to give a transfusion. And some of those symptoms might be bleeding as associated with low platelets, chest pain from severe anemia, or very severe fatigue from low red blood cells. So if a patient is having symptoms, I care very little about what the numbers are and much more about helping the person feel better. In the absence of symptoms, there are some cutoffs that we use that we sort of consider safety cutoffs for transfusions. From a hemoglobin or red blood cell perspective, the recommendation is that we transfuse anytime the hemoglobin falls below 7 grams per deciliter. Normal hemoglobin is somewhere between 13 and 15. So this is a pretty big decrease from the normal level that we wait until we reach that level before we give a transfusion. Now, you may be thinking to yourself, well, Dr. Wilde, at my cancer center, they transfuse my hemoglobin when it's below 8. And I will say that this is absolutely true. These are just guidelines, and there is some variation in practice from place to place. Older guidelines recommended transfusions for a hemoglobin of 8, but some newer studies that have come out have shown that people feel equally as well when their hemoglobin is allowed to go down to 7. And then we're really minimizing risks of transfusion. So in general, the recommended threshold is a hemoglobin below 7. And in terms of platelets, we want to think about transfusing platelets as a preventative mechanism, meaning in the absence of symptoms, when the platelets fall below 10,000. This is very far from normal. Normal platelets are above 150,000. So we wait until the platelets are very low before we think about transfusing. Once platelets fall below this 10,000 threshold, this is when patients are at risk for more spontaneous bleeding complications. And so we don't like to let the platelets go below 10,000. Now, again, every place is different. So there may be different thresholds that your cancer center uses. It may be that if you're getting close to 10, you might get a transfusion before you quite get to that level. So these are all logistical and individualized practices, but these are really the general guidelines. And I just want to stress the most important thing is the person in front of me. So if symptoms are present, that's really what I'm focusing on fixing primarily. Let's talk a little bit about the actual nuts and bolts of how we give transfusions. So what happens when your doctor orders a transfusion for you? So the first thing that happens is that your doctor checks your blood type with a blood test. And that blood type is then used to help select the right type of blood product for you to receive that day. Excuse me. The blood transfusion and platelet transfusions both have to be given through an IV. It can be given through a regular old peripheral IV, a central catheter like a PICC line, or a port, depending on what a person has. So any of those can be used to administer a transfusion. When the blood product arrives to the infusion center or wherever you are, your vital signs will be monitored before, during, and after the transfusion, usually every 15 minutes. So this is really to monitor for complications or transfusion reactions, and we'll be talking about that in a little bit. How long a transfusion takes really depends on the kind of blood product that you're receiving. In general, red blood cells, 1 bag, take about 2 to 3 hours, and 1 bag of platelets takes about 1 hour. There are circumstances where they take longer. So you can imagine that this can be really burdensome if you need to arrive to the transfusion center, wait for your blood type to be drawn, wait for the blood to be ready, and then get several hours of transfusions. This can really be a whole day affair. So when I'm thinking about the cost of transfusions to patients, not just thinking about the dollar cost, but I'm thinking about the cost in time. Needing transfusions really takes a lot of time. And so we want to be mindful of that and try to minimize the need for transfusions for so many reasons as much as possible. So if you have MDS, what's the likelihood that you'll need a transfusion? The reality is that the vast majority of patients with MDS will need a red blood cell transfusion at some time during their disease course, up to 90% of people. And many people become dependent on these transfusions to maintain their hemoglobin at that level above 7. For some people, this means transfusions every week or every other week or every month. It's very individualized, but it is a common occurrence in MDS treatment. And about 50% of patients will need at least 1 platelet transfusion within the course of their disease. So red blood cell transfusions are more common, but platelets are commonly required as well. So transfusion dependency is a big problem in MDS disease course. What are we aiming to do with these transfusions? And why do we take on the risk? I think I've already set the stage for the complications that can happen with low blood counts. So you can imagine that we're trying to prevent or reverse these complications with transfusions. So with red blood cells, we're trying to improve those symptoms of anemia, fatigue, shortness of breath with activity, chest pains or abnormal heartbeat. Those are all things that we try to fix with red blood cell transfusions. We also want to help people feel better and be more active and functional in their daily lives. So increasing one's ability to work or participate in their family life or their community is a big goal of red blood cell transfusion. With platelet transfusions, we're aiming to prevent bleeding. So skin bleeding, gum bleeding, nose bleeding, or more serious kinds of bleeding are all things that we're trying to prevent with platelet transfusion. We also want to improve functional outcomes. So patients who are having repeated bleeding or becoming anemic from bleeding on top of their MDS, these are things that really decrease quality of life and functional abilities. So we want to use transfusions to support patients to help them feel better. But all of this support comes with risk. And so we're going to spend the next couple of minutes talking about some of the risks associated with different types of transfusions. And when I'm thinking about these risks, they fall into 4 big categories: risk of infection, risk of transfusion reaction, risk of iron overload, and risk of antibody formation. And if this all sounds like something you've never heard of before, that's okay. We're going to spend some time going into each one of these in detail, but these are sort of the general categories of risk of transfusion. Infection is probably the risk patients ask most about because it's something that people have heard of before. Transfusion-transmitted infections are actually very uncommon, particularly in the year 2022, given all of the testing that we do on the donor blood supply before it ever gets to the patient's bedside or chairside. This is a chart from a paper that was published in 2019, quantifying the risk per unit of transfusion of a variety of different kinds of infections. So this table is broken down into virus infections, bacteria infections, and parasite infections at the bottom of the table. So I'll just talk in general categories here. When I'm giving a consent for a transfusion, I always address the risk of infection. And what I can say is that the risk of developing an infection like HIV, hepatitis B, or hepatitis C from a blood transfusion is about 1 in 2 million or 1 in 3 million. So extremely, extremely rare. The risk of developing a parasite infection like malaria from a blood transfusion is also exceedingly rare, approximately less than 1 in 3 million. So the biggest risk of infection from a transfusion is actually a risk of bacterial infection, usually associated with platelet transfusions. And this is because platelets are stored at body temperature, as opposed to blood, which is stored in the refrigerator. And so pathogens or bacteria don't like to grow at cold temperatures, but can grow at body temperature. So the risk of a bacterial infection from a platelet transfusion is higher than the risk from a blood transfusion. And this is about 1 in 100,000. Again, it's very rare. I think I've seen 1 in the past 5 years. So, it's not something that's commonly seen, but it is a higher risk than the risk of a viral infection transmitted by a transfusion. So in general, I think the takeaway message here is that transfusion is very safe now because of the screening that we do on donor blood. Moving on to transfusion reactions. There are several different kinds of reactions that can happen during or after a blood transfusion or a platelet transfusion. And these reactions can range from mild reactions like allergic reactions to the most severe kind of reaction, which would be getting the wrong blood type. I'll start with the wrong blood type first, and I'll say that these type of reactions should never, ever happen. The way we do testing on blood type and donor units in this day and age is with multiple layers of checks. So computer checks, human checks at every step of the way. So we consider this a never event, meaning no one should ever get transfused with a unit of blood that's not the correct blood type for them. What's much more common in terms of transfusion reactions are what we consider mild allergic reactions or fever reactions. Allergic reactions can look like a bunch of different things. For some people, it may be a mild rash or itching that happens during the transfusion. On a more severe spectrum, it could be difficulty breathing. In general, if this happens, we treat it like any other allergic reaction, first and foremost by stopping the transfusion, and then by giving medications like Benadryl or other kinds of antihistamine medicines to stop the allergy from happening. Other types of reactions like fevers or swelling can occur with blood transfusions or platelet transfusions. Again, if these happen, the first thing we do is stop the transfusion and investigate and treat whatever symptoms the patient may be having. So this could mean Tylenol for a fever. It could mean a water pill to treat swelling. But in general, these reactions are mild and can be managed outside of the hospital in the outpatient setting. And then finally, there's a rare lung reaction or lung injury that can happen with transfusions. It's very uncommon with blood and platelets and much more common with that type of transfusion called a plasma transfusion that we don't use very often anymore. But this is something that is a risk that I always counsel patients about. The most important thing to remember about transfusion reactions is that most are mild, most can be treated in the outpatient setting, and that having a reaction once does not mean that you will always have a reaction to transfusions in the future, nor does it mean that you need special treatment necessarily before you get your next transfusion. There are some centers that preventatively treat patients with medications like Benadryl or Tylenol before getting a transfusion, but in general, this is not recommended and has never been shown to really prevent the occurrence of these kinds of reactions. So our practice and the recommended guideline practice is to reserve preventative medicines for really specific situations. And that's something that you should discuss with your care team. So the next risk of transfusion specifically applies to red blood cell transfusion. And this is the risk of something called iron overload. 1 unit or 1 bag of red blood cells contains a lot of iron. I put here that it's 200 milligrams per unit. I think that's kind of a meaningless number for most people, but just know that that's a lot of iron. And the human body is super good at absorbing iron, but doesn't have a good way to get rid of it once it's inside the body. So what happens is that iron deposits or gets stuck in different organs in the body. It can get stuck in the liver, it can get stuck in the heart, it can get stuck in the glands like the thyroid gland. And once it's stuck there, it is very hard to remove it. Iron overload can happen once a person has had between 10 and 20 red blood cell transfusions. So this is something that I'm always monitoring for in my patients with MDS who are getting repeated red blood cell transfusions. When iron overload happens, we can treat it with medications called chelating agents. And these are medications that, in my mind, I think about act as little sponges. They go in and they try to hook onto and sop up that iron that's stuck in different places. The problem with these iron chelating medicines is that they have a lot of side effects and can be very difficult to take. They can also be very expensive and hard to use. So I think the best treatment for iron overload is to prevent it from ever happening in the first place. And that's why we're so focused on researching and trying to develop new treatments that decrease transfusion requirements for patients with MDS so that we never get into this problem of iron overload in the first place. And then finally, the last kind of big category of risk for transfusions is something called antibody formation. Antibody formation can happen in both red blood cell and platelet transfusions. And these antibodies are proteins that the immune system produces in response to something foreign. In the time of COVID, we've spent a lot of time thinking and talking about the antibodies that we make when we get a vaccine. That's the same kind of concept here, which is that the immune system sees something that's foreign and makes an antibody that says, aha, the next time I see this foreign thing, I'm going to latch onto it and get rid of it. It's great if that foreign thing is a virus that you've made an antibody to. But if it's a red blood cell or a platelet, well, we're transfusing those because a patient needs them. And so antibodies can be really problematic. This picture here is showing a red blood cell. And these little blue circles on the red blood cell are what we call antigens. I think of these as little flags that live on the surface of the red blood cell. There are also flags that live on the surface of platelets. And so these flags are what the antibodies can see and are formed against. So the next time you receive a red blood cell or platelet transfusion that has those same flags on the surface, those antibodies will stick to it. That's those little Y-shaped things here. The antibodies will stick to it and then remove that blood cell. When that happens, the transfusions aren't as effective, and this can be a big problem. Now, we can identify these antibodies, and then we can search for blood or platelet units that don't have those flags on the surface to help make transfusions more successful. But once those antibodies are formed, they don't like to go away. So if someone makes a lot of antibodies, you can imagine that it can be very difficult to find units of blood or platelets that are successful for transfusion. So over time, this can become a big problem. These graphs over here are meant to show that with time and with increasing numbers of units of blood, the risk of developing antibodies increases. So if we focus on the graph here labeled B, what this is showing is that by the time a person has received 20 units of red blood cell transfusion, about 70% of those people who get to that 20 transfusion mark will have developed at least one antibody. Same thing with time. As transfusions increase over time, the probability or the likelihood of developing an antibody to that red blood cell transfusion goes up and up. So the more we can reduce the need for transfusions, the more we reduce the risk of antibody formation. So how do we do that? I mean, it sounds, everything I've told you so far is that transfusions are super important in the treatment of MDS, and I fully believe that. But they're a double-edged sword because they have a lot of risks associated with them. So I mentioned that we're looking for alternatives to red blood cell transfusions. So let me tell you a little bit about what the alternatives are that we currently have. The first thing we have is something called an erythropoietin stimulating agent. There are several called erythropoietin or darbepoetin. Sometimes we refer to these as Ippo or an ESA, all sort of the same, referring to the same thing. It's just that erythropoietin is a long word to say. And I'm going to talk to you now about how this works. So this picture is showing you how Ippo normally works. Ippo is a chemical that's made by the kidney. When someone has anemia or low hemoglobin, the kidney senses that and it says, aha, we need to make red blood cells, and it makes more Ippo. That Ippo chemical goes through the blood to the bone marrow, and it tells the bone marrow, hey, wake up, we need more blood cells. And the bone marrow makes red blood cells. Using an Epo stimulating agent is basically bypassing the kidney and giving extra Ippo as a medication to stimulate the bone marrow to make more red blood cells. Now, you might be thinking to yourself, how can this happen, right? The factory's broken in MDS. And you're exactly right if you're thinking that. That's the problem. Depending on how broken the bone marrow is, how poorly that factory is working, that really determines how well Ippo therapy will work. So for some people, if the bone marrow still has some ability to make red blood cells, giving more Ippo can stimulate it to make anemia better. But for some people, the bone marrow is already too broken for Ippo to really be effective. So whether or not your care team has decided to try Ippo is dependent on how well they think you might respond. The good things about Ippo are that it's pretty safe and it has pretty few side effects in terms of what people feel after they get the treatment. Some of the downsides of Ippo treatment are that, one, it has to be given by an injection or a shot. So nobody likes a shot. It can be painful. It also has to be given pretty frequently. So it does still require that you come in and get injections on a regular basis. Responses to Ippo are often modest. So it may take your hemoglobin from 7 to 8 or 7 to 9. But in general, we're not seeing jumps from 7 to 14. So the improvement in hemoglobin is often modest. And it can be expensive depending on the insurance situation or, what sort of healthcare costs you're incurring. So I think that in the right situation, we certainly reach for Ippo products a lot to try to help minimize the need for transfusions, but it's not a perfect treatment. The other thing I'll say is that having a good response initially to Ippo treatment does not necessarily mean that that response will last. And it's hard to predict how long Ippo will continue working. So for many people, we start using it and we see an improvement, maybe even no need for transfusions at all. But over time, the effectiveness of the Ippo treatment goes away and we're back to thinking about transfusions and moving on to other kinds of treatment. The next treatment that we have that's an alternative to red blood cell transfusions is a treatment that was recently, in the past couple of years, FDA approved. That's called Pattercep. And Pattercep is a unique medication that works to find immature or baby red blood cells and tell them to grow up into older, more mature functioning red blood cells. So it works a little bit differently than those Ippo treatments. This graph is from the study that was published comparing Pattercep treatment to placebo or no treatment at all. And what it shows here in the graph is that after 8 weeks of treatment, many more people in the Pattercep group had a response and improvement in their hemoglobin than patients who were receiving the placebo. And that response was really maintained over time. So patients who are taking Pattercep can become transfusion independent, meaning don't need transfusions at all. And so this is a good option for patients with a certain subtype of MDS. The pros of Pattercep are that it too is very safe and has very manageable or minimal side effects and can make you transfusion independent over time. So this is a good option. I think on the con side, it's also an injection. It's given less frequently than Ippo, so that's a little bit nicer, but it is still a shot that you have to come in and receive. Response rates were modest. Only about a third of patients in the study became transfusion independent over time. So for patients who responded, it was great, but that was not the majority of patients. And then finally, it takes time to work. This isn't something that you come in and get one shot and suddenly your hemoglobin's better. I wish it were, but it's just not that fast. So time to onset can take many weeks and increases in doses. So we have to use patience when we're using this treatment. And I think that that can be difficult. So Pattercep is definitely a step forward in minimizing transfusions. It's being studied in patients with all different subtypes of MDS and in combination with other treatments. So I think this is just the beginning of understanding how we're going to use this medication to minimize red blood cell transfusions. And then finally, alternatives to platelet transfusions. At this point in time, there's no FDA-approved treatment for minimizing platelet transfusions. There are platelet stimulating agents that sort of have the similar concept to those Epo stimulating agents that exist. They are approved for other uses and definitely are under investigation in the treatment of MDS, but as yet are not approved. So in terms of low platelet count, really the treatment that we have is transfusion and transfusion alone. And then finally, just a word about disease-modifying treatment for MDS. Disease-modifying treatment is medications, as I mentioned, like chemotherapy. And we really reserve disease-modifying treatments, particularly in lower risk MDS, for when we have nothing left to choose from. Now, the decision to use chemotherapy in higher risk MDS or MDS that's closer to acute leukemia is a much, much different picture. But I think really it's an individualized decision about when to implement disease-modifying treatment, particularly to try to fix low blood counts like anemia or thrombocytopenia. So this is a conversation to have with your care team. And then finally, what's on the horizon? So I just this morning quickly did a search of clinicaltrials.gov to look at what's out there. Searching for MDS and transfusion, I found 53 studies, and I kid you not, the first study that's listed here happens to be a study that I'm running, and I did not plant this. But this is a bunch of studies that are looking at how to better utilize or optimize the use of transfusions or minimize the use of transfusions in patients with MDS. And so I put this here to show you that there is hope for better treatments on the horizon. There's a lot of active research in this area. So my take-home points are really as follows. MDS causes abnormal blood cell production in the bone marrow. Most patients with MDS will need blood and or platelet transfusions at some time in their disease course. Transfusions should be used sparingly as they have many possible risks. And treatments for MDS are often aimed at decreasing or eliminating the need for transfusions. And then finally, just a word for those of you who are listening who may be friends or family members of someone with MDS, or for those of you who have MDS whose friends and family members ask, how can I help? We are in a critical blood shortage right now, nationally and internationally. The COVID-19 pandemic has made this much, much worse. We are seeing critically low levels of red blood cells and platelets around the country. And so if someone is thinking about a way to help out the MDS community, if you're able, blood donation can really help save lives. So every 2 seconds, someone in the US needs a blood transfusion. That's not just patients with MDS, but all sorts of different needs. And so really, we implore you that if you're able to donate blood, it would help us and it would help the MDS community. And with that, I will close. Thank you so much for your attention. And thank you again to the MDS Foundation. And I will be happy to take any questions that are asked of me.
Thank you, Dr. Wilde, for your wonderful presentation. And thank you for addressing the blood shortage, which is in desperate need right now. Your donations are really needed. And thank you all for joining us today. For those who haven't sent in your questions, you can start submitting your questions in the chat box found on the bottom menu bar. And for those who want to revisit this recorded webinar, a viewing link will be sent to all registrants and will be available on the MDS Foundation website for on-demand viewing within 10 business days. All right, let's proceed to the live Q&A. Please bring your questions. Our first question comes from Fred. He wants to know, how does Spattercept work, and does it help kill cancerous stem cells?
That's a great question. Spattercept is a really cool and unique medication. Unfortunately, it doesn't, as we know of, target cancer stem cells. What Spattercept does is really give baby red blood cells a signal to grow up. So it stimulates those newly formed red blood cells called reticulocytes. and encourages them to mature faster so that they can go out into the bloodstream and do their job. So Luspatercept is really considered a supportive treatment similar to transfusions, but not really a disease-modifying treatment, meaning we don't think that it really changes the MDS itself or the progression of MDS.
Thank you, Dr. Wilde. The next question comes from Richard. He says, currently, Reblozyl, Spattercept, is only given to patients who are transfusion dependent. Do you feel that it will be eventually prescribed more broadly? Also, what is the success of and what are the side effects of Reblozyl?
Yeah, great question. So I'm going to start with the effectiveness and the side effects, and then I'll talk about where I think we're going with this medication. So about a third of patients in the seminal study for Luspatercept had a response of reducing their transfusion needs or becoming transfusion independent. So really that's, 30 to 35% is not an overwhelming response rate. So it's great for the patients for whom it works, but frankly, for a lot of patients, it's not successful. In terms of side effects, there's a range of side effects. I think the most common things are injection site pain or reactions, fatigue, and then some GI side effects like diarrhea have definitely been the most prominent in both the studies and in my practice. Oftentimes they're manageable, but I think that I have seen a handful of patients, particularly where the diarrhea was just not something that we were able to handle with supportive medications. So those are the big side effects. In terms of how we use this medication, it was studied in a very small subset of patients with MDS, with a particular kind of MDS called MDS with ringed sideroblasts. So MDS is a rare disease, and this was a small piece of the MDS population that was studied initially with this medication. So now there are other studies ongoing looking at Luspatercept in the broader MDS community, and also combining it with other medications. So I think this is really just the very beginning of us understanding how to use this medication. Ultimately, my hope is that it will be able to be safely paired with other treatments, and that maybe we can combine mechanisms of action of Luspatercept plus something else to help either with anemia or with anemia that comes from MDS treatment. So I just think it's the tip of the iceberg for this drug.
Thank you, Dr. Wilde. Richard wanted to comment that your presentation was excellent.
Thank you.
The next question is, how are infections treated post-transplant transfusions?
I think, was it post-platelet transfusions?
Oh, I'm sorry. Yes, post-platelet transfusions.
That's a great question too. So the most common infection, as I mentioned, with platelet transfusions is bacterial infection. And that's really because platelets are stored at body temperature. And so bacteria can easily grow at body temperature and not in the refrigerator where we store red blood cells. If someone develops a bacterial infection because of a platelet transfusion, we try to identify that bacteria, and then we use antibiotics to treat it. It usually requires IV antibiotics because these are usually bloodstream infections because, of course, the platelets go into the bloodstream. So, we do blood cultures to try to identify the bacteria, and then we give antibiotics that are appropriate for that bacteria that we've identified. At the same time, we go back to that transfused unit of platelets and we test the transfused unit to make sure that that is truly where the bacteria came from. And then obviously this goes back to the blood supplier, and we sort of try to figure out how it happened. But the vast majority of these infections are treatable with antibiotics.
Thank you. The next question comes from Richard. He wants to know, is fresh blood more effective than blood that is not as fresh?
This has been studied a lot over the years, and there's been some conflicting data. The short answer is probably not. Red blood cells that we make in our body live for about 90 days. When we put red blood cells in the refrigerator, we're able to sort of store them and keep them from dying. It is true that there are older red blood cells, depending on the age of that unit of blood and how long it's been stored. But there really haven't been any good studies that have proven definitively that fresh blood is better. Frankly, during the blood shortage, we don't have the luxury of choosing. We try to use whatever's on the shelf as fast as we can. But so oftentimes with red blood cells in particular, we use what we have available to us. Platelets actually only last for 7 days after they're donated. So all platelet products are very fresh because by the time they've been collected from a donor, taken to the blood center for testing, and then delivered back to a hospital or a clinic, usually the shelf life of platelets at that point is only 5 or 3 days. So all platelets are very fresh.
Thank you. Fred wants to know, do deferricerox and jade new help remove iron that may be deposited in the organs?
They do. So iron chelators can extract deposited iron that has built up in the tissues. So that's, why we focus so much on implementing them or using them at the right time, because we want to try to reverse some of those effects of iron deposition. The problem is that even if we can remove the deposited iron, sometimes that iron has already caused irreversible damage to the liver, let's say. So even though we may be able to get the iron out, depending on how long it's been there or how much there may be irreversible damage to the tissue, even if we're able to chelate the iron away.
Thank you. The next question comes from Jagannath. He has a hemoglobin of 8, and he wants to know whether blood transfusions or erythropoietin injection is suitable and helpful to reduce the low hemoglobin symptoms like fatigue.
So it is very difficult, especially for someone who has a hemoglobin right around 8. I think that, as I mentioned in my talk, the general recommendation is to transfuse for hemoglobin 7 or below. That being said, many people are symptomatic with hemoglobin closer to 8 or between 8 and 9. So it's really a very personalized approach. Usually, if I'm not sure what the situation is, or if the anemia is really the cause of a patient's symptoms, I'll say, okay, your hemoglobin's 8, let's give you a unit of blood today, and then let's track what your symptoms are so that we can try to tease out, okay, if I give you a unit of blood and your hemoglobin goes from 8 to 9, do you suddenly feel like Superman? Or do you really not feel that much better? And maybe the transfusion is more risk than benefit. So I really do try to tease that out carefully by symptom tracking. In terms of the Epo Stimulating Agents, I think, again, it depends on how frequently someone is requiring transfusions, whether or not it's time to try to implement one of those agents. What the recommendation is that we actually check a patient's Epo level. So we check to see how much Epo your body is naturally making. If that level is 500 or below, we think that maybe your body would respond to the Epo injections. And so we decide to give it a try. If you're not requiring transfusions, then it's probably not necessary to start that medication because it's just added time coming into the infusion center or time coming into the clinic, but you may not be deriving benefit from it. So we really wait until someone is requiring red blood cell transfusions, and then we check the Epo level to see if it's worth starting an injectable Epo agent.
Thank you. Great answer. The next question is from Mary, who has low-risk MDS, transfusion dependent, requiring 2 units of red blood cells every other week. She's failed Procrit, Vidasa, and Spattercept, and her ferritin level is a 6,800, and she's had over 115 units of blood and is treated for iron overload. Iron chelation drugs have had serious side effects, and her oncologist has stopped them. What other treatments can she try, and when does the iron overload start affecting the organs?
This is a really tough situation, and I'm sorry that you're going through this. It is hard to tolerate a lot of the iron chelating medications. They do have a lot of side effects, mainly because they help you excrete the iron in the stool. And so the GI side effects like diarrhea can be really, really difficult to manage. I think that in terms of understanding how the iron is affecting your body, with a ferritin level in the 6,000s, I would be recommending that you have an MRI of the liver and an MRI of the heart. We can actually use MRI to quantify the amount of iron that's been deposited in those tissues. And so that can help us to understand how the iron is affecting your body. So that's one thing. The second thing is that, other than iron chelators, we don't really have any good options for iron removal. In people who have a disease called hemochromatosis, which is where their body sort of naturally becomes iron overloaded because of a genetic change, the treatment for that is to do phlebotomy or to have them donate units of blood. And clearly, that's an efficient way to get rid of iron from the body, but we can't do that in MDS because you need the transfusions. Your bone marrow isn't making red blood cells. So phlebotomy is by far the best way to get rid of iron, but we don't have that option. So outside of iron chelators, there aren't a lot of options otherwise. I will say that the next things to think about are, really trying to fix the MDS itself. And it sounds like you've already had one chemotherapy, Vidasa. There is other chemotherapy, and there are clinical trials out there that would potentially be an option to consider as other MDS disease modifying agents so that we can try to reduce the need for further transfusions and prevent additional iron overload.
Thank you, Dr. Wilde. The next question comes from Alyssa. Have there been any patients on Spattercept that had some success and then had to stop because it was no longer working and were able to go back on it after a period of time? Her dad started it right after it was approved in May or June of 2020 and had some early success. The longest being 9 weeks transfusion free, and then fewer transfusions prior to being on the medication, average being every 3 to 4 weeks. Now they're back to transfusing every 2 weeks or less. His hemoglobin is always between 7 to 8, and sometimes he sees an 8.3 or an 8.4 after a transfusion. His transfusion threshold has been set to transfuse if less than a hemoglobin of 7.8, but not sure how long this will be the case with the blood shortages we are facing in Southern Nevada.
Yeah, this is tricky because a lot of places are really, being understandably more strict about their transfusion thresholds. I come back to my previous point. I mean, where I practice, we have a strict threshold. So anyone who I want to transfuse whose hemoglobin is over 7, I do need to directly talk to our blood bank. That being said, our blood bank is almost always willing to listen to us when we say that this is an individual patient who needs a transfusion. Sometimes we're transfusing half units of blood because we're trying to be more judicious, but it is a problem we're facing more and more. I'm hopeful that as this COVID wave sort of wanes, we'll see a pickup in blood donation, and that will hopefully help alleviate some of the stress. I think in terms of the question about being able to go back to Pattercep after someone has lost a response, it's not something that we truly know. There hasn't been a study that has looked at that. Personally, I haven't tried that, and I'm not aware of anyone who's had success with that approach. That being said, we've already talked a lot about the fact that our options are really limited in what we have in terms of medication support to reduce transfusions. So personally, I don't think it would be unreasonable to try it again, since we don't have a lot of other things to choose from outside then of chemotherapy. So I wouldn't be opposed to trying it. I would just have to warn the patient that, we really don't know if there's any chance for success. And I think hopefully future studies will better answer that question.
Thank you, Dr. Wilde. Stephen wants to know, what happens if we run out of blood?
Whew, let's hope that never happens. We have to make some difficult choices. So as I mentioned, we're already doing things like transfusing half units of blood. I think other things that we're seeing happen in places around the country, unfortunately, is that things like elective surgeries are being postponed. Because a significant amount, we're focused on MDS here, but really a significant amount of blood products go to surgeries or traumas. So emergency situations, we have to reserve blood for those. But elective surgeries where we reserve blood for possible transfusion during that, those might get postponed so we can try to preserve the blood supply for those who need it most. I think that there is so much interest in developing synthetic blood products or, coming up with other creative ways to sort of stimulate blood cell production or support blood cell production. But all of these things have been variably successful in the past or are under investigation. So right now, really the best thing that we can do is encourage people to participate in blood drives, to donate when they're able, and then hopefully encourage doctors like me and care teams to really think closely and critically about how we use blood products to make sure that we're preserving them for people who need them the most.
Thank you, Dr. Wilde. Olivia wants to know, do you see a synergistic effect using Spattercept in combination therapy with Fredicrit?
That hasn't been studied. I have definitely seen them used together. I'm not sure that I've really noticed a big synergistic effect. But it is a great scientific question and one that is definitely under investigation. The idea being that if you could stimulate the bone marrow to make more baby blood cells and then give the Pattercep to help grow them up faster, maybe that would be sort of a dual targeting method. But that's not something that we have data for yet.
Thank you. We may have covered this, but Loranda wanted to know, for which subtype is Luspatercept most effective?
Sure. Luspatercept has been studied and is approved for patients with a subtype called MDS with ringed sideroblasts. There's pretty specific criteria for how that's diagnosed based on what's seen in the bone marrow biopsy. It is a small subset of patients. I will say that even though that is where the medication has been approved, I certainly have seen it used outside of that small subset of patients, but that's an off-label use. No guarantees that insurance would approve it, and really hasn't, that those studies haven't been published yet. So if you're following the FDA approval guidelines, that is only for MDS with ringed sideroblasts.
Thank you. The next question is, can being hospitalized on a saline IV distort hemoglobin readings? Could the saline dilute the reading to make the reading lower than it is?
So sometimes we do see a dilutional effect from people getting IV fluids. So when, for example, someone is very dehydrated and, doesn't have a lot of extra fluid in their body, it can make the hemoglobin or the blood very concentrated. And so sometimes when someone comes into the hospital and is dehydrated and we give them IV fluids, we see a drop in the hemoglobin because we've rehydrated and put the fluid back into the blood. So that can definitely be seen. Once someone is adequately hydrated, that dilutional effect is less and less. So generally, if you come into the hospital and you're not dehydrated, if we give you IV fluids, that should not drop the hemoglobin very much. But that's a great question.
Thank you. Stephen wants to know, how do we treat antibody development?
So antibody development is usually treated by trying to bypass those antibodies, meaning not everyone's red blood cells or platelets have the same flags on their surface. And there's actually many, many, many of them. So we all know about the basic blood types, A, B, and O, but there are actually lots of other flags on the red blood cell surface, for example. And so we actually can do pretty specific typing looking at all of those flags. So if I know that someone has 3 antibodies to 3 specific flags on their blood cells, well, I can ask that the Red Cross or whoever's delivering the blood to send us blood that doesn't have those flags. So no flag means that the patient's antibody won't react with the blood cells at all, and that a transfusion should be effective. The problem is that over time, the more antibodies that you have and the more flags that they're targeting, the more difficult it is to find that sort of specific blood that's lacking those flags. So the more antibodies you get, the more difficult it is. Platelets are the same thing. Everyone's platelets have a different combination of flags on the surface. So we can screen, identify those antibodies, and look for platelets without them. If anyone has ever heard of HLA matched platelets, that's looking for platelets that are lacking certain flags that are specific for those antibodies that a patient might have. So matching is really the way we try to get around antibodies.
Thank you. Sergio wants to know if you phenotype the red blood cells of the patients with MDS before the first transfusion.
So there is a way to genotype and phenotype red blood cells. That's generally not how we do the typing unless it's for research purposes. What we do before someone starts getting transfusions is just basic blood typing, looking for their regular AB, or O blood type. And then, we keep that on file, and that way that's how we know how to get appropriately matched blood for an individual. But most blood banks don't do full genotyping or phenotyping on the blood unless it's for a research study.
Thank you. Jagannath wants to know, he has a hemoglobin of 8 with ring sideroblasts greater than 50%. He wants to know whether blood transfusions or erythropoietin injection or Spattercept is more suitable and helpful to help him with his symptoms.
So I think it depends. I generally take a stepwise approach because for people who have low risk MDS, this is really a bit of a marathon disease. I'm expecting that patients will live for a long time, I'm hoping, with their MDS and will be able to manage it. So oftentimes I start with transfusions and see sort of how frequently the transfusions are required and how much they're helping with symptoms. If transfusions are, not working or they're very frequent, then the next step that I take is to check an Epo level to see if I think that person will have a good response to Epo injections. If the Epo level is less than 500, I start with Epo, because Epo is really sort of our longest used and kind of best studied medicine in this situation. And then I kind of ride the Epo out for as long as I can, for as long as it's effective. Once Epo becomes ineffective and the transfusion requirements are starting to increase again, that's when I move on to Luspatercept. I use the Luspatercept for as long as it's working, and then I move on after that. So I try to do this in a stepwise fashion based on symptoms and how effective the prior treatment is or has been. I don't think it's wrong to go straight to Luspatercept in the situation that you're describing with ring sideroblasts. But I wouldn't start Luspatercept until someone is transfusion dependent, just because, it really is designed to decrease transfusion requirements. And so if you're not requiring them at all, then no reason to expose yourself to medication side effects.
Thank you. The next question comes from Inez. If I'm understanding correctly, it's not in question form, but she's on Aranesp. And I think what she's asking is every 3 weeks she has a urinary tract infection. Is this common?
That's not an association that I'm aware of between getting Aranesp injections and having frequent infections. I think, my other questions would be about what the white blood cell count is, because we certainly know that red blood cells aren't the only part of the blood system that's affected in MDS. So perhaps the infections are more related to the MDS affecting the white blood cells. But as far as I know, Aranesp itself shouldn't put you at risk for recurrent infections.
Thank you. Jennifer wants to know if there's any evidence that maintaining a hemoglobin with a more liberal frequency of transfusions in any way suppresses the marrow's ability to produce red blood cells and platelets.
There is not any evidence of that because really the transfusions, the problem in MDS, as we've talked about, is really that the bone marrow there's been genetic changes in the bone marrow that are making it difficult for blood cells to be made appropriately. So that genetic change is there no matter what, regardless of whether you're getting transfusions twice a week, once a month, whatever. So the driving mechanism of MDS is that broken bone marrow. So no matter what, the transfusions are really there just to fix symptoms and prevent complications, but don't alter how the bone marrow is functioning in terms of those genetic changes that have already happened.
Thank you. The next question is, can blood transfusions cause fluid overload in the lungs and lead to acute respiratory distress?
They can. So there are a couple of different ways that blood transfusions or blood product transfusions can cause fluid overload. So for people who already have problems with fluid overload, particularly people who have heart problems like heart failure, getting a transfusion of blood is a pretty significant amount of fluid. Platelets are much less fluid. There's much less fluid in the bag, but a red blood cell unit is a lot of fluid. And so it's about 500 milliliters of fluid. And so if someone already has heart failure or requires diuretics or water pills to maintain their fluid balance, getting a blood transfusion can really put them at risk of fluid overload. And so sometimes for people who have significant heart problems, we actually give them a medication like Lasix or a water pill right away after they get a blood transfusion to help avoid problems with fluid building up in the legs or in the lungs. There are also transfusion reactions outside of this that can cause fluid to build up in the lungs. There's something that we refer to as TACO. It stands for transfusion associated circulatory overload. And that just really is a reaction where when someone gets a blood transfusion, they just all of a sudden have a buildup of fluid, and it can happen in the lungs primarily. So same treatment for that. When that happens, we give usually a medication like Lasix or some other water pill to try to get rid of that fluid when it builds up. If that happens, that TACO reaction, the next time we have to give a blood transfusion, we give it very slowly. We try to prevent it from happening again with giving more of those water pills. And sometimes we even will split a unit of blood in half and give it very, very slowly in 2 parts to try to help the body handle all of that fluid. There are some other very rare transfusion reactions that can also cause fluid buildup in the lung. They primarily happen with plasma transfusions, which is not something that we use very often and is not something I almost ever use in patients with MDS. So that doesn't tend to be a problem here.
Thank you. The next question comes from a patient not taking transfusions. They want to know, do you have to come off Eprex before using Spattercept?
You don't have to, but in the study you did. So as I said, I've seen it used at the same time. That's not my general practice because that's not how this Pattercep was studied. So usually I use them sequentially, but not combined.
Thank you. The next question is, are there patients who have gotten transfusion units in the hundreds?
There are. And I think we actually had a question from someone earlier who said they had received over 115 transfusions. It is, as I said, this can be a bit of a marathon in terms of this disease. We see people who live with low-grade MDS that require transfusions for 10 or 20 years and can be quite transfusion dependent over that time. So, we do see people who have had transfusions in the hundreds over many, many years.
Thank you. The next question comes from Bob. He's had MDS for 6 years and went through RNS, then transfusions for a year. Spattercept has been used for a year, is now waning. His doctor now is adding Procrit to the Spattercept. And he wants to know, do you have any experience with the two together?
Yeah, as I was saying, I have definitely seen the two used together. In my experience, I have not seen an additive effect, and we don't really know that there is one. Again, I think it makes sense to want to use them together, but it's not something that we have a study or data to tell us how to do. I think oftentimes the desire is to avoid chemotherapy. And so, people are trying to use them together, I think, with the hope that we can draw out the use of these less toxic treatments as long as we can before we have to move to the next level of therapy, which for many people is chemotherapy and is a big jump. So again, no data for the combination of Epo agents and Pattercep, but definitely something that we're all thinking about and studying.
Thank you. The next question is, which MDS medications can be taken orally?
So there is, in terms of the Epo Stimulating Agents and Pattercep, they are injection only. There is a oral form of azacitidine or Vidasa, and there is an oral form of decitabine or Dacogen. The oral form of Dacogen is called Inqovi. This is the one that has been studied best in patients with MDS. And so is something that I'm using much more frequently. I'm also switching people over who've been receiving IV Dacogen to the oral therapy because they've been shown to be equivalent in terms of how well they work. They're very, very similar in terms of side effects. And it's much, much nicer to take 5 days of a pill at home than it is to come in 5 days a week for an IV. So the trend is definitely moving toward oral therapy for patients with MDS in the chemotherapy space. But nothing yet in terms of Epo stimulating agents. And as I said, Pattercep is also an injection.
Thank you. The next question is, what are the most common side effects of Epo and Pattercep?
So both of them share the risk of injection site pain and reactions because they are shots. Epo, in MDS, Epo has been shown to be very well tolerated. I think that it does not have a lot of side effects for most people. In other diseases where Epo was studied, the major concern was blood clots. And the reason for that was that it was being used to try to support people, particularly people with non-blood cancers who were receiving chemotherapy. And so they were getting treated with Epo to hemoglobins, back all the way into the normal range. And what they saw with that was that the more Epo you gave and the higher the hemoglobin got, the higher the risk was of having a blood clot. We generally don't see that in MDS because we're not treating to a hemoglobin above 10. But for everyone's general knowledge, once a person's hemoglobin reaches 10, we stop the Epo injections until the hemoglobin falls again. So I do have patients who their hemoglobin gets to 10 or close to 10, and we can skip some of the injections. So that's the major concern with the Epo agent. Luspatercept has additional side effects of fatigue. I've seen some bone pain, and it was reported in the study. And then gastrointestinal side effects like diarrhea seems to be the predominant bothersome side effect for some people. I've seen a little bit of headache occasionally with it, but many people have few or no side effects at all.
Thank you, Dr. Wilde. The next question comes from Loranda. Why can't platelets be irradiated to prevent infection risk?
So irradiation is used for platelets and red blood cell products, but for a different reason. So irradiation targets white blood cells, but that doesn't necessarily fix the infection risk problem. So the way the irradiation works just doesn't target bacteria. So unfortunately, it's not an effective strategy. There are other strategies that we use for platelets in terms of trying to reduce the risk of infection. So first of all, we test all of the units for bacterial infections prior to a patient getting the transfusion. We also store them on like a little moving shelf to try to keep them from sort of sticking together and increasing the risk of infection and complications. But thus far, there's no irradiation technique that can prevent bacterial infections. But if someone wants to invent it, I highly support that.
Thank you. The next question comes from Mark. He has had Pattercep with no success and has had 40 transfusions in the past 12 months. What would you suggest could be my next treatment step? His diagnosis is MDS with ring sideroblasts and myelofibrosis unclassified. His current hemoglobin runs in the 6.5 to 7.5 range.
It's a tough situation. And I think it depends on whether or not we think the MDS or the myelofibrosis is what the major cause of the anemia is. This is what we call an Mds Mpn Overlap Syndrome. So the bone marrow has some features of myelodysplastic syndrome, but also some features of this thing we call a myeloproliferative disease, which is sort of a cousin of MDS. And that's where the fibrosis comes from. There are actually clinical trials out there that are looking at treatments for patients with these kind of Mds Mpn overlap syndromes, but they are often very difficult to treat. Chemotherapy like Vidaza or Dacogen is an option in this situation. I highly recommend that patients with overlap syndromes consider clinical trials because we have very few studied or approved medications for this group. So I think clinical trial or chemotherapy are probably the next steps. We do use other medications called JAK inhibitors. Ruxolitinib is one of them for patients with myelofibrosis. It's a medication that's targeted at changing or reversing some of that fibrosis. The problem with ruxolitinib is that it's not always so good for people who have a lot of anemia. So that may not be a great option. We can combine that sometimes with other agents like chemotherapy. So this is a pretty complicated situation, and one that I think, clinical trial or chemotherapy, unfortunately, is probably the next step.
Thank you, Dr. Wilde. The next question is from a patient who has MDS with ring sideroblasts and multilineage dysplasia. They have the SF3B1 gene, and from 7 weeks at start 3 years ago to the present time, their transfusion need has gone to 2 bags every 14 days now. Soon this will be even shorter. At what point do treatments need to be considered, and what can these be?
So I think the time is now to implement some other treatment. Your transfusions are very frequent. And you actually, have the kind of MDS that is shown to respond best to luspatercept. I think it would be reasonable to both check an Ippo level and see what your Ippo level is and whether or not trying an Epo stimulating agent would work. And if the Ippo level doesn't suggest that that's a good option, then luspatercept would definitely be my recommendation at this point.
Thank you. I think that the patient is mentioning that that luspatercept is not an option because it's not approved in Sweden.
Got it. Yes, that is true. And so I think that probably I would start with an Epo stimulating agent if that's the case.
Thank you, Dr. Wilde. At what point do you start chelation for iron overload? And do they work on iron deposits in the heart as well as the liver?
So chelators do work for iron deposited in any tissue in the body, heart included. And I start thinking about a chelator when someone is between 10 and 20 units of blood into their transfusion course. We screen with a test called ferritin. Ferritin is a blood test that we use as a sort of surrogate marker of what the iron level in the body is. Our goal is to have a ferritin less than 5 or 400, depending on which guideline you're looking at. If the ferritin is over 1,000, you absolutely want to be thinking about starting a chelator. That ferritin doesn't really get to that level until you've had between 10 and 20 units of blood. So that's usually around 10 units is when I start screening.
Thank you, Dr. Wilde. I think we may just have time, unfortunately, for maybe just 2 more questions. The next question is from Alyssa. In reference to her previous question, how well would someone tolerate and respond to Vidasa at the age of 88? And thank you for your presentation. It was fabulous.
Thank you. And 88 is not too old for Vidasa in my book. One of the nice things about Vidasa and Dacogen is that they are relatively low in terms of experienced side effects. I think that, things that we associate with traditional chemotherapy, like nausea, vomiting, diarrhea, are in most people minimal or non-existent with these medications. The biggest risk of starting a chemotherapy like Vidasa is the fact that as it works to try to fix the bone marrow, it makes the blood counts worse before it makes them better. So oftentimes we see reductions in white blood cell count, hemoglobin, and platelets when someone starts treatment with these medications. And then over time, as the chemotherapy helps to fix the bone marrow, those blood counts improve, hopefully back to normal. That's the goal. But during that time that the blood counts are low, patients can require more transfusions in the short term or be at risk for infections. So infection risk is something that I worry a lot about anytime in someone of any age. That being said, I've treated patients with Vidasa or Dacogen in their 90s and had them tolerate it very well over a long span of time. So I think as long as everyone understands the, potential risks associated with it, I certainly don't think age of 88 alone is a reason not to try.
Thank you, Dr. Wilde. The last question comes from Mary. Would you recommend a stem cell transplant for a low-risk MDS patient who is transfusion dependent, having had over 115 units of red blood cells and ferritin over 6,800, and who has previously failed Vidasa and luspatercept?
Good question, Mary, and thank you for it. I mean, I absolutely would consider a transplant in this situation. I think that it sounds to me like you've really maxed out all of the other options that we have available to us. And so it is reasonable to consider a transplant in this situation. It's always a big decision and finding a donor and accepting sort of the risks associated with stem cell transplant is certainly a conversation that you need to have over a period of time with your care team and your support system, family and friends. But I definitely do recommend transplant consideration in that situation.
Thank you, Dr. Wilde, and thank you for your presentation today and for donating your time. For those that have any questions for me, those that went unanswered, please email me at ahassan@mds-foundation.org. And just to repeat, the presentation from Dr. Wilde will be available on the MDS Foundation website for on-demand viewing within 10 business days. On behalf of the MDS Foundation, thank you for joining us. This concludes our presentation today.